Hello my friends, welcome back to my channel with a new video, and this is a part 2 of the Sepsis Unplugged series, and this is the final video. So let's start. So in short, what is our journey so far? Starting from the fluid strategy, which we know, the famous reverse trial in 2001. It's almost 25 years now, where the cumulative fluid were about 10 liters, as you could see, and it was about 168 ml per kg as a as a combined dose. So from this particular strategy, we have come down to a restrictive strategy, as we have discussed, and the journey has been from the process trial in 2014, where the cumulative fluid was close to 8 liters. Arise trial in 2014, the cumulative fluid was about 6.5 liters. Promise trial in 2015, where the fluid was about 6 liters. Rifts in 2019, the cumulative fluid was about 2.8 liters. Refresh trial in 2018 with a cumulative fluid of about 2 liters. The classic trial in 2022 with a cumulative fluid of about 1.7 liters. And of course, Clover's trial in 2023 is about 1.2 liters. So from 10 liters, we have come down to 1.2 liters. And what does the evidence glaringly tells us? That more the restrictive strategy, more will be the ventilator free days, less easy will be the weaning, and probably it may have a mortality benefit when we when we will know the more and more trials which are going on in the near future. So talking about the bundles, where we know of the targets of mean arterial pressure of about 65, which is a strong evidence and a strong recommendation and moderate quality evidence. So for septic shock patient, we recommend administration of antimicrobials immediately within 1 hour of recognition. Uh, and without shock, the administration can be within 3 hours. For the same category of patients with high risk of MRSA, there is recommendation of MRSA coverage. And of course, with the patients having a multi-drug resistant organisms, there is a recommendation or suggestion of 2 antimicrobials with gram-negative coverage. And of course, in a patient with a high risk of fungal infection, empiric antifungal therapy will definitely come on the cards after the initial antimicrobials which we deliver. So these are the few of the recent guidelines which all the trainees of critical care should know. The same case gets continued, so we do a focus on that patient, and we find this acute calculus cholecystitis with pericholecystatic fluid and fat stranding. The gallbladder is distended with irregular wall and intramural gas. IVC is about 14 millimeters, and there is more than 50% of the collapsibility index. We do a 2D echo with a good LV ejection fraction of 60%. LVOT VTI is about 22 centimeters, so it is actually okay. If anything, more than 18 is fine without any, suggestion of cardiogenic component into that. Cardiac output is a hyperdynamic circulation, say about 12 liters, and pulse pressure variation of about 14%. Again, it suggests that we can give the fluids to this patient. So of course, the surgeon was involved because we had this case of acute calculus cholecystitis in septic shock, and one of the anesthesiologists who was involved, because we also contemplated that whether this patient should go in the theater. So it was suggested that since the patient is so sick, how can he go to the theater, or how can she go to the theater? And there was a suggestion of addition of levosimendan. So as an intensivist, our lookout and our opinion should be that she is so sick that she has to go to the theater. If you don't take care of the source, the patient will never improve. This is the only chance you can give to the patient. So this has to be understood very well, that however sick is the patient, this is the only chance and we have to insist upon anesthesiologist and surgeon that this patient goes to the theater. Of course, with the supportive care, the antibiotics, the fluids, the monitoring, and so on and so forth. Of course, antibiotics, the source control is the mainstay of any septic patient who comes to you. Antibiotics have been recommended as prolonged infusions, especially for beta lactams. Any intravascular device needs to be out if it is the source of infection. And when there is a window of opportunity, we should be thinking about the de escalation of antibiotic and as short duration as possible whenever it is started. And of course, the procalcitonin and the clinical condition will help us to discontinue or de escalate the antibiotics. Of course, as we know, procalcitonin is not something where you can diagnose sepsis. Procalcitonin is not something where you decide about starting the antibiotic or delivering a broad spectrum antibiotic. It is mainly used to de-escalate with the trend of the PCT, which you do maybe on the day 0, then day 3, day 5, and day 7, and so on. So the trend is more important than one particular value, and that holds true for not only procalcitonin but also all the clinical parameters and the lab parameters, especially for a patient who is critically ill. The newer kind of biomarkers in the form of pre-sepsin, SUPAR, and genomic signatures are definitely on the horizon, and we may actually see this getting done more often than not. So the same case got operated, the patient got ventilated. As you could see that this patient has ARDS. There's incremental doses of noradrenaline of more than 0.3 micrograms per kg per minute. The patient was oliguric, she had uremia, metabolic acidosis. So a nephrologist was involved, and he suggested, of course, along with the renal replacement therapy, he also suggested polymyxin B hemoperfusion, and surgeon suggested for IV immunoglobulin. And we will discuss in my next slides as to what is the evidence of these particular strategies. So as far as hemodynamic support is concerned, noradrenaline is the first drug of choice, followed by vasopressin and then adrenaline. Dobutamine is added in few subset of patients who have cardiac dysfunction and persistent hypotension, of course, to increase the cardiac output. So as we know that the blood pressure depends on the cardiac output and systemic vascular resistance. There is definite no for terlipressin, levosimendan, and dopamine. So that is a very clear-cut message. And of course, invasive arterial pressures is something which is a norm and which is very commonly done in all the ICUs across the board for such patients. Vasopressors through peripheral line still can be given at one particular doses. So not necessarily to start with, you need to have a central line. Later, you can start a noradrenaline through a peripheral line. As far as ventilation is concerned, HFNO is preferred over non-invasive ventilation, and a standard ARDS ventilation of low tidal volume of about 6 ml per kg, target plateau pressures of about 30 millimeters of mercury, high PEEP, the target driving pressures also needs to be looked at, say about 15 or 16, recruitment maneuvers with incremental PEEP, the pulse pressure or the prone position ventilation where the patient is not improving, intermittent neuromuscular blocking agents, and what is recommended at present point of time is cisatracurium, and of course VV ECMO for patients who fail the conventional means, and of course for the hospitals or the setups who have the infrastructure for the ECMO. So this is about the ventilation. As far as additional therapies in sepsis are concerned, for a persistent shock, IV corticosteroids, that is hydrocortisone in the dose of 200 mg per day, and it is commonly given in the dose of 50 mg IV 6th hourly. And polymyxin B hemoperfusion, there is no evidence as of now. There is no evidence for IV immunoglobulins in sepsis. Stress ulcer prophylaxis, yes. Low molecular weight heparin for DVT prophylaxis is certainly recommended. Of course, as in this patient, as you could see, intermittent or continuous renal replacement therapy was instituted. There is probably at present point of time there is no role of high dose vitamin C. You need to control sugars of not more than 180. Maybe a control between 150 to 180 is something which is fairly okay. Early enteral nutrition is extremely important to use the gut for these patients, and we usually start this patient if they are not in shock. And of course, even if they are on noradrenaline, if the dose is less than 0.25 to zero point 0.3 micrograms per kg, I think there is definite recommendation to start some trophic feeds in very small doses of say 20 to 40 ml, and then going up and achieving the target in the next week or so. So definitely palliative care whenever appropriate. We need to know the patient's status, if it's a stage 4 malignancy or if it is a end stage lung disease not for transplant. We need to think about the palliative care. The same case was extubated on ninth day. The shock improved. She was off RRT and shifted out of ICU on the 12th day, and eventually she was discharged. So this was a good outcome. What are the futuristics in sepsis? Probably we are looking at a precision medicine. All of us know AI and ML has already come into our field, and they are definitely going to go up in the next few years. The phenotyping of one particular disease, especially ARDS, is obviously something which we are looking at. Metabolomics, AI/ML, as I said, telemedicine, and of course rapid molecular diagnostics, the multiplex PCR studies which are done. So this is just in short, as we discussed about 2025, what the sepsis unplugged from guidelines to bedside. So we need to have protocols, we need to monitor the patient, we need to have early recognition of sepsis with fluids and antibiotics and source control, and of course we need to actually have the biomarkers which will help us to decide about the antibiotics, and a combined approach will definitely work towards improved patient outcomes. So that's all for now. Thank you.